Hello, everyone. Welcome to this important webinar on the changing landscape of E&M codes for 2021 and what do you need to know. With the upcoming changes in the E&M codes, there has been a lot of focus on proper documentation, and there are also very important guidelines on medical decision-making, risk assessment, and many more important topics that we will cover in today's webinar. So hello again, I am Diya Ranjan, and joining me in today's webinar as a panelist is Jennifer Giladi. Jennifer is the Senior Client Manager for Revenue Cycle Management Services at Bismatics. Jennifer has 21 plus years of experience in billing and RCM services. So let's all welcome Jennifer. A few important housekeeping items as always before we begin. We do have a question and answer session at the end of Jennifer's presentation. So please type in the questions in the question box and send it over to us, and we will answer them in order. Secondly, the recording and slides of the webinar will be made available to all of you in a follow-up email, and Prognosis customers will be able to access it from our resource center. So let's begin. Welcome, Jennifer, once again. The session is all yours now.
Well, thank you, Dia, for that wonderful introduction. Hello, all. My name is Jennifer Gilardi, and I'm excited to talk to you today about the 2021 Evaluation and Management Code changes, as well as conversion factors. So we have a lot of good information on these slides, and it's a plethora of information and knowledge that we need to go into 2021, understanding the new guidelines, understanding the proper coding, and how we can all work together to make sure we maximize our revenue. Okay, so let's get started. So 20 and 21 E&M changes summarized. So let's talk about that. So in 2021, CPT code 99201 will be deleted. So why is that? The reasoning is based on the fact that 99201 and of course 99202, they're associated with that straightforward medical decision making. So with that being said, the history and physical exam will no longer be a parameter for that level of service selection. So again, 99201 will be deleted. Very important. A provider can either determine the E&M by MDM, which is your medical decision making, or based on time. And we will talk thoroughly through that throughout the presentation. Medical decision-making guidelines have changed, and I think they're for the better, so I'm very excited to talk about that. Level of history or exam are not a requirement in determining an E&M level, and I'll get more into depth with that as well. And this is exciting. Non-face-to-face work is now included in the time if done on the same day as the visit. Okay, our history and physical, our exam. So complexity is going to guide the coding over bullets and systems. Okay, so what does this mean? So the first notable change is going to be there will no longer be a requirement for a specific level of history and exam. Moving forward to 2021, history and exam need only be relevant and pertinent based on the reason for the visit. And we'll talk about that more in depth as well. Their efforts will now focus on the level of your medical decision or the time as defined by that code description. So there's no required level of history or an exam for a specific E&M level to be met. So in layman's terms, this means a more localized physical exam approach will now apply. So I took a quote from the AMA website, and I really want to read this verbatim and I want it to resonate with this audience here today. The office or other outpatient services include a medically appropriate history and/or physical examination when performed. The nature and the extent of the history and/or, very important, physical examination is determined by the treating physician or other qualified healthcare professional reporting the service. So the care team may collect information, and the patient and caregiver may supply that information directly. And ladies and gentlemen, we can get this through different avenues, by the portal, through the questionnaire. So there's lots of different methods that we could use for this. This is great. So that is reviewed by the reporting physician and or other qualified healthcare professional. So the extent of the history and physical examination, your HPI exam, is not an element in selection of the office or other outpatient services. So I really took this quote and wanted to have everyone understand that, the changes that are coming, this is really an important quote, and I really want this again to resonate with you. Okay, this is another exciting slide. Changes to time in 2021. So I wanted to put it side by side. So in 2020, as you can see, we have our established codes and we have our new patient codes. So it's a conversion to what 2021 is going to look like. So I would like to go through these codes separately so everyone is well aware. So in 2020, our 99212 was 10 minutes. Now up and coming here in a few weeks, 99212 is going to be 10 to 19 minutes. So we need to be well aware of this change. 99213 in 2020 was 15 minutes, and 99213 is now going to be 20 to 29 minutes. A little bit of a jump there. 99214, 2020, 25 minutes. 99214 coming up here in a few weeks, 30 to 39 minutes. Another significant jump. 99215, 2020, 40 minutes. And in 2021, 99215 is going to be 40 to 54 minutes. So those are your established patients. The time changes. All right, let's go to the new patients. So your 99202. Now, ladies and gentlemen, what's missing on this slide? The 99201, because remember, that has been deleted. So your 99202 is 20 minutes. And now your 99202 is going to have a range of 15 to 29 minutes. So that's a big change there. Everyone needs to be made aware of that. 99203, your 30 minutes is now going to go to interval of 30 to 34 minutes. Your 99204, 45 minutes, remain a bit static, but extending the time, 99204, 45 to 59 minutes. And then of course, our 99205 at 60 minutes in 2021, this code will now have an interval of 60 to 74 minutes. So I really think this slide's very important, and we need to understand, the changes and ensure that the proper minutes are selected, and we're selecting those codes. Okay, AMA, American Medical Association. So now we're going to talk about items included in time. So let's talk about, per the AMA, what are the lists of the activities performed and the time associated to each activity, okay? So now with time, preparing for the patient may include reviewing of tests and history of referring providers. So non-face-to-face. So let's say you're reviewing the records. You're on the phone for an authorization, non-face-to-face. So for coding purposes, time for these services is the total time on the date of the encounter. It includes both face-to-face and non-face-to-face time personally spent by the provider. So some of the activities, I'm going to just scroll through, prepare to see the patient, the review of any tests, obtaining or reviewing separately obtained history, performing a medically necessary exam and or evaluation. This is really important, ladies and gentlemen. Counseling and educating not only the patient, the family, and the caregiver. I'll repeat that. Counseling and educating the patient as well as the family and the caregiver. Ordering medications, tests, or procedures. Referring and communicating with other healthcare professionals. Of course, we're not reported separately. So let's say we're talking with another ancillary doctor outside of the office or a PCP. Documenting clinical information in the electronic or other health record. That will count. Independently interpreting results, again, not separately reported, and communicating results to the patient as well as the family and the caregiver. And then, of course, care coordination. So with that being said, the appropriate time must, and I say again, must be documented in the medical record when it is used as a basis for code selection, okay? So it's very important. All right, you are not allowed to include time, staff time that if you're having anything on hold, like let's say you're calling for an authorization and your staff's making the call. And we're gonna go through that in a couple of slides, but any type of ancillary work like that, you cannot include that kind of time. And we could be a little more specific in a few slides. I have some examples. So again, just briefly want to go through the slide again. Preparing for the patient, reviewing the test, examination, counseling and education, very important. Ordering your procedures and your meds, looking at imaging. That's not face-to-face. We can count that. That's fantastic. Discussions with other healthcare professionals, interpreting results. So now I want you to note, if the physician is billing a modifier 26, which we all know is that professional component, he or she cannot include this in the time spent. I repeat, cannot include this in the time spent. You cannot include time on an item separately reported, i.e. like care management or an EMG, and the list can go on and on. Those are just two examples. And it has to be done on the same day as the visit, very important. All right, so let's take a look at a time example. Let's run through this, okay? So you spend 30 minutes face-to-face with the patient. Let me record that as 30 minutes. You spend another 20 minutes on the review of history. So what does review of history mean when it comes to time examples? Reviewing another physician's medical records outside of your office, ladies and gentlemen. Very important statement right there. We have to make sure it's outside of your office. Again, you cannot include staff time, so any other ancillary things that you're doing to, like I said, get an authorization, which I'll show you in the next one about hold times, and any items that's really not pertinent to the documentation. We want to make sure, we want to stick to the proper minutes and make sure our claim goes out clean. 10 minutes spent on a peer-to-peer review with insurance company for authorization. So I'm on the phone with Blue Cross Blue Shield of Florida, and I'm on hold for 30 minutes. But in that 10 minutes, there was a peer-to-peer review to intercept the authorization. I'm counting that 10 minutes. That's not going to be 40 minutes. We cannot use that hold time. Very important. 10 minutes spent ordering. Very important. Ordering any medicines, any therapies. We need to calculate that. 10 minutes spent in consultation with another physician when not separately billed. Again, when not separately billed. So let's calculate the minutes. As you see, the 30 and the 20, the 10, the 10, and the 10, the total time comes to 80 minutes. So with proper documentation and all these bullets, this is a very good example of how to document time. And you have to be very clear and concise. And remember those key words. That second bullet's very important. If you're reviewing records, they have to be outside of your office. So we want to make that clear. And again, I just want everyone to stay abreast of all the changes. Of course, we're having this webinar today, and we'll go through a lot of information, but my suggestion is to stay abreast of all of the AMA and CMS and MGMA guidelines that are out there. All your payers, they're all going to behave a certain way. And just, I really want you to stay abreast of all these issues and stay informed. Okay, documenting time spent in prognosis templates. So here's an example. We're rolling this out in the near future. If a provider is using time to select his or her E&M level, it's very important that the time spent is documented within the progress note. So as you take a look at the slide on the left, what's missing? R99201. So it's not even there for you to select. So prognosis has that feature there for us as well, which is fantastic. So as you can see, you have your 99202 to 99205, and to the right, you see your time factors. So that's for your new. Now your established patients, you have your 99211 to your 15 and your time factors. So these are, I just wanted to give you a bird's eye view of what the EMR EHR templates would look like as we're selecting these, and how it, and these templates are very important, how they're going to guide you into your coding. So that's very important. Documentation. So as we all are very well aware of our 1995 and 1997 guidelines. So these guidelines were based on, of course, the bullet point system from your history and physical and your past family social history, your review of systems, and your physical exam, along with MDM to support the levels of service. So we all know that, we live it, we breathe it every day. Well, in 2021, there's a change. MDM, medical decision-making, will now be the primary determination of levels of service, okay? So the new 2021 guidelines, it's gonna focus on documentation that supports your MDM, of course, and your diagnosis. So therefore, items such as, let's say, labs, x-rays, any other type of other ancillary services, along with their interpretations, will need to be documented within the notes, okay? So those ancillary services need to be documented within the notes. That is the major change from prior documentation, and we want to make sure of that. Very important. Okay, let's review the requirements for MDM. So medical decision-making will have 3 elements when determining an E&M. So let's walk through those. The number and complexity of the problems being addressed during the visit, okay? The amount and or complexity of the data to be reviewed and analyzed. And we'll talk about that in a minute. Risk of complications, morbidity, and or mortality of patient management. Okay, so I want you to stay honed in on analyzed, the word analyzed, and patient management, okay? Because this is part of the change. 2 or 3 elements must, I repeat, must be met. 2 or 3 elements must be met. Okay, another one of my favorite slides, our handy dandy grid. And I'm just going to show you that the 15's right there. It's just lots of information, as we all know, so I had to put it to 2 slides. But wanted to make sure you had all the information. All right, so we already talked about MDM as the prime determinant of level of service, okay? We talked about that. So it's expected that the conversion to MDM as a basis for the level of coding, ladies and gentlemen, it's going to require some planning and preparation on the part of the qualified healthcare providers, okay? MDM has always been a part of our algorithm, if you will, for choosing a level of service. But now, the sole determinant of the level of service is going to be our key component, unless the provider intends to bill based on time, okay? And we'll go through some examples. So MDM in 2021 will be based on the number and complexity of the problem addressed, the amount and or the complexity of the data reviewed and analyzed, and the risk of our complications and or morbidity and mortality of patient management, So number and complexity of problems addressed in the encounter. Let's talk about that piece of the grid. So the greater, let's talk through this. The greater the number and the complexity of the problem, okay, let's say, addressed at the encounter, the higher the applicable level will be of decision-making. So this ranges from your straightforward to your low, moderate, and high. So several specific problem levels, you'll need to figure out, where we are with those elements, okay? They range from self-limited or minor problems to either acute, chronic illnesses, or injury. Okay, so a lot of times physicians will struggle and say, well, this isn't clear. Does it constitute a self-limited or a minor problem? So for this reason, there's specific definitions in the AMA and CMS website to limit any confusion. So I have added that to the slide. So these guidelines will help you select in your coding process. All right, so the amount and or the complexity of the data to be reviewed and analyzed. Let's hone in on that word, analyzed. So this category in the middle here, it attempts to quantify the amount of the data, efforts to gather your data, and of course your communications utilized to evaluate your patient, okay? So the collection of more data obviously leads to a higher level of MDM. So your levels will include minimal or none, limited, moderate, and extensive. So the data is divided into 3 categories. Let's first start with that. So let's say category 1, you have your tests, your documents, orders, review of prior external notes. Category 2, independent interpretation of tests not reported separately. And category 3, discussion of management or test interpretation with external physicians, other qualified healthcare providers, and appropriate sources, not reported separately. So to determine the amount and the complexity of the data, we always want to refer, if we're having issues, to that AMA website that can give us more clarity if you're having trouble in the selection process here. All right, so let's look at the risk of complications and or the morbidity and mortality of patient management. So this is an assessment of the relative danger of patient management. So whether from treatment or further workup, levels are minimal, low, moderate, or high. Okay, so let's talk about that. Some treatments are relatively risk-free. Let's talk about, I don't know, an over-counter medication or like a dressing change. But then you have some that are highly risky, such as a decision to perform emergency major surgery. So that level can vary. So to estimate the risk of complications, it may be helpful to understand and be familiar with the definitions of, for example, risk, morbidity, social determinants of health, drug therapy requiring intensive monitoring, and the definitions, again, are in your AMA website, which I've referenced, okay? So once the level of your presenting problem is established, the data is reviewed and the risk management is determined. The overall level now of the MDM can be determined, okay? Again, to qualify for a particular level of MDM, 2 of the 3 elements for that level of decision-making must be met or exceeded. And I'm going to repeat that. To qualify for a particular level of MDM, 2 of the 3 elements for that level decision-making must be met or exceeded. Very important. That's going to determine the level of your E&M service. Okay? So please be clear that this new method of determining your level of E&M service is going to require some changes to physician behavior and documentation, okay? And again, we're all in this together. So billers, coders, physicians, we're all learning this, as we go along. So we can all lean on each other and learn. So this is a good thing. Providers will need detailed instructions, system changes, and practice using the new E&M codes and the new methodology, okay? Okay, so here's this is just a screenshot of the 99205 and 15, and that will be sent to you as well. All right, so let's take a look at a coding example. Okay, so a patient presents with severe knee pain. See the word severe. Let's look under that number and complexity of problems addressed. It goes right to the 99204 or 14, whether they're new or established. See that high severe exacerbation? Okay. Physician then discusses a comorbid condition in the history and physical NAP. Okay. It's minimal or none. You're still in the 9920414 category. The practice performs and bills for both the professional and technical component of an X-ray. We're in the moderate section. So with that being said, the documentation has to support the 04 and the 14, because we don't want to get in a situation where we have to come back and revisit that. And what if it was a 13? So we really have to pay attention. The grid is going to be, very important to us in selecting these codes. Okay. Okay. So it's very important to note that if you are billing for the interpretation and a report of a diagnostic test, it cannot be counted when determining the level of an MDM, okay? We want to ensure we mitigate denials, okay? So let me give you an example. A patient gets an injection of Toradol. That's an administration of an injection for a non-steroidal anti-inflammatory. So the Toradol is not included in the E&M, okay? It's not included in the E&M. Okay. Incident to billing. So what does that mean? It's been out there for several years, and people say, Jen, explain this incident to billing. It keeps coming up. Well, there's been some additions to that as well. So let's talk through that. The supervising MD must be present in the building, okay? There's no new patients or no new problems that can be seen under incident 2 guidelines, okay? No new patients or new problems. Okay, so here's where the minutes come in. So for counting time under the new E&M guidelines, if the physician assistant or nurse practitioner spends 30 minutes with that patient and the supervising MD spends an additional 10, the total time for that visit is going to be 40 minutes. Now here's where it gets, we need to pay attention. They cannot be in the room at the same time and add their time together, okay? They cannot be in the room. So if the PA or NP is in there for 30 minutes, doc steps out, working with another patient, and then when the doc comes in and is working with that patient, that's when you can add the 10 minutes, okay? We want to make sure we're really precise with this in our time calculations, again, to avoid any denials or issues, with our coding, okay? Here's another one of my favorite slides. Okay, we have a new prolonged service codes, ladies and gentlemen. It is 99417. 99417. So this code, it reflects, of course, a prolonged office or other evaluation and management service that requires at least 15 minutes or more of total time, either with or without direct patient contact on the date of the primary E&M services. So there's that or again, with or without direct patient contact, okay? So 99417, this prolonged service, let's talk about it. So we know each 15 minutes. Bill only with E&M codes 99205 and 99215. It is not allowed to be used with any other codes. So please be aware of that. Used when time is selected, select the E&M code. Okay, and that can be used for face-to-face or non-face-to-face time on the same day of the visit. Okay, do not report anything less than 15 minutes additional. Okay, so here we go. We have an example, 7 minutes over the time on the E&M code does not count. So let's say you're almost there, you're at 7 minutes. We are not allowed to report that. It has to be at least a 15-minute interval. So let me give you a good example. So 99417, we have over 75-minute example here. So if we have 89 minutes, what is that coding combination going to look like? It's going to be a 99205 times 1, of course, and your 99417. Okay, I needed that. So, okay, again, you may not report the new prolonged service. In addition, if you're reporting based on MDM, 99417 is out of the game when coding MDM. So please know that. Okay. All right, let's talk about conversion factors. Okay. So CMS has mandated a 10% reduction for the year of 2021. So with the budget neutrality adjustment to account for changes in the RVUs as required by law, the proposed 2021 PFS conversion factor is now $32.26. So that's a decrease of $3.83 from current year 2020 that we're in now, where that used to be $36.09. So let's take a look at a calculation. So how is this going to affect us? How is this going to affect the practice? So let's take the conversion factor for 2020, $36.09. So you have your conversion factor, which we all know, times our total RVU is always going to equal our allowed amount, which is our reimbursement. So let's take 99213, for example. In 2020, currently today, you have your RVU at 192. We times that by $36.09. We have $69.29. 2021, ladies and gentlemen, in the next several weeks, that RVU at 192 needs to be multiplied by $32.26, which equals $61.94. That's our 10% reduction. And again, this is CMS mandating this 10% reduction. Okay, so I wanted to give some key takeaways in the slides. So changes apply only to the office and other outpatient E&M services, your 99202 to your 99215. CPT code again, 99201 will be deleted due to low utilization. Providers will select the E&M code based only on the level of MDM, medical decision making, or total time. History and examination will no longer be significant in determining the level of service. Total time is defined as total time spent on the day of the encounter. Okay? We reviewed revisions to the MDM and MDM elements for codes 99202 to 99215. Okay, so let's look at some of the changes. So the number of diagnoses or management options will now change to number and complexity of problems addressed. Amount and or complexity of data to be reviewed will now change to amount and or complexity of data to be reviewed and analyzed. Remember the couple slides I honed in on that word analyze, okay? And risk of complications and or morbidity or mortality. This will change to risk of complications and or morbidity or mortality of patient management, okay? So what can we do? What can we do as healthcare professionals to go through 2021 very seamless? We can become more familiar with the definitions of problem types, risks, any other elements of service that will need to substantiate these levels of MDM. We all need to be aware, from the coder to the biller to the physician to the payment poster, okay? We all need to be in the know. Healthcare professionals learn to routinely document items within notes that will be used to score your MDM, including ordering your tests, x-rays, interpreting your tests and x-rays, requesting review of outside documents, having discussions with other healthcare providers, and using other independent historians aside from the patient. I mean, that's a nice change. But again, we need to utilize our services from AMA, CMS, AAPC. There's so many vendors out there and governmental constituents that are going to give us this information and help us. So I know it's a lot of information and there's been a lot of changes, but again, we're going to get through it and we're going to work hard in making sure our KPIs are very well intact. So that concludes my section of the presentation. Dia, I'm going to turn it over to you for the question and answer session.
Thank you, Jennifer. Thank you to you
Thank
for, yeah, thank you for the comprehensive information you provided for the revisions to the E&M codes. And I think your examples would have further cemented the concepts that you very well explained. So we are hoping that today's session would be very, very useful for our attendees. So with this, we are now open for question and answer session. And so you can type in your questions and send it to us. And Jennifer, we do have quite a few questions, so let me begin. So the very first question, when using the medical decision-making process, how many elements must be met?
Okay. 2 or 3 must be met. Okay, very, very, very important. We talked about that on several slides. When using the MDM decision-making process and the MDM methodology, 2 of the 3 elements must be met.
Okay. Moving on to the next question. Does one base their time based on whole time spent? For example, we are specialists and we do X-ray procedure, etc. So that's the question. Let me know if you want me to repeat it again.
Yes. So are they asking? So the time spent, they're a specialist. The documentation needs to support everything that they're quantifying. Does that make sense?
Mm-hmm. Okay. For the next question. If you want
to further investigate that, I will, Dia, as well, and I could give them an example in an email, no problem.
Okay, I will note that one for you, Jennifer.
Okay, perfect.
All right. So the next question. So for incident to billing, as long as the doctor is in the building, not in the office, can it be billed?
Yes, the doctor has to be in the building. The doctor has to be in the building, okay? That's very important. We talked about that on slide 14, that definitely the doctor has to be in the building, okay?
All right, and this is interesting, Jennifer, because this is again on incident to billing. The question is,
okay.
Can you please go over the incident to billing update again? Thank you. So maybe if it is okay for you to go over that slide and, go over it again, or do you want to? Okay, all right.
Several minutes and we could read through that. Because I know this middle part could be confusing, with a lot of patients, patient movement and physician offices can be different. So the supervising MD must be present in the building. No new patients or no new problems can be seen under incident 2. Okay, so the PA and the NP, they're in the room with the patient, or either or, spends 30 minutes with the patient, whether it be assessing, and then the supervising doctor comes in, okay? PA will leave. The 10 minutes that the doctor spent can be added to that 30 minutes. They cannot be in the room at the same time and add their time together. Kristen, do you want to add to that?
The only thing that I would add is, under incident 2 billing, again, the provider has to be in the building. So he can't be like next door at home. That wouldn't qualify for incident 2. And then 2, you can't add your time together if you're in the room together.
Yep.
and the provider can only add time if he actually physically goes into the room and sees the patient. So if he's just reviewing her chart notes, that doesn't count.
Yep, exactly. All right, thanks, Kristen. Dia, next question, please.
Yes. So the next question again relates to one of your slides where you talked about the knee pain example. So the question is,
Okay.
in your example of severe knee pain, what would the complexity be if the knee pain is not chronic?
Okay, so if the knee pain is not chronic.
Right.
Kristen, add to this one for me. Do you have any additions to that?
So, I mean, what was the question one more time, Dia?
So in your example of severe knee pain, what would complexity be if the knee pain is not chronic? So the knee pain is not chronic.
So if it's acute, you would technically be on low, which is
Low, yeah, low.
99203-213. So you would basically be at the 3 series level.
Mm-hmm.
And then depending on how you answered the second column and the third column, that would determine if you stay at a 3.
Yes, exactly. And so that's why I put that severe in there to make so the patient presented with that severe knee pain. So that severe exacerbation was selected. But we can go into more depth via an email, Dia, if
Okay.
the participant needs more information. I will definitely investigate that for the participant. Thank you. Next question.
Okay, the next question is, so 99417 can be used by itself as long as it is on the same day of appointment.
And yes, and it cannot wait. It's a prolonged service code, so it cannot be used with MDM. It can only be used as time dates. Okay.
All right. Okay, moving on. What about therapy codes like 90834 and 90837?
Okay. So they're therapy codes. So both 90834 and 837. Let me just go back to my.
So I'm just gonna clarify.
Isn't that
These changes
therapy?
do not have anything to do with any other codes except
Yeah.
the 99212 to 99205. Therapy
Mhm.
codes, hospital codes, they're still the same old way. These changes have nothing to do with those codes.
Okay. So actually, that kind of cements the next question, Jennifer and Kristen. So the question is, what are the changed CPT codes for 2021?
Again, just like Kristen said, these guidelines only pertain to 99202 to 99215. And why did I start with 99202? Because 99201 is deleted. Thank you, Dia.
Okay. All right. So the next question is actually related to prognosis. It is, when can we expect the templates to be available in prognosis?
I knew that was coming because they look beautiful. Kristen, I'm going to let you answer that one.
So that would be sometime in January. We are expecting these changes.
Right. We're hoping that they'll be released before January 1st. You will see the notification that your system is being upgraded. When you log in, you'll get like that alert that will pop up on Prognosis, and it'll tell you the date for your upgrade.
Great question. Very exciting as well.
Okay. Right. The next question is, where can we find these changes in writing? I think this is meant for resources, right?
Right here.
Yeah, so you can go to like AMA's website, CMS's website, AAPC, Coding Intel. They all have all of these changes in writing with the documentation.
Okay.
Like I said earlier, ladies and gentlemen, anytime there's a webinar that will pop up, such as the one we're speaking of now, I would suggest to join them and get a plethora of information, because it really substantiates all these new changes. Okay.
Mm-hmm. Okay, moving on to the next question. When will MCR publish updated fee schedule? And will Prognosis develop templates for time to aid providers in documenting time?
All right, so the Medicare fee schedule,
Mm-hmm.
usually publish that. They're asking for the 2021 Medicare fee schedule.
I think it's already out.
I think so.
I believe
that.
if you go on CMS's website, they did publish some of the 2021 stuff already.
Yeah, I want to say December 1st they did it, but don't quote me on that. Let's see. Yeah, I want to say December 1st. They have the CMS.gov. So this CMS.gov right here, that'll give you all your information, and it's excellent information. Very straightforward.
Okay. All right. Okay. So the next question, what are the main factors in coding the new prolonged service code 99417?
Okay, so the 99417, again, must be billed only with your E&M codes 99205 and 99215, and ensure that it is billed within that 15-minute interval. Anything less than 15 minutes will not count for proper coding. So please always remember that. Thank you, Dia.
Okay. Moving on, the next question, if we draw lab today and will not have results until next day, but where do we document the results? Hold the open chart and document when we get them, or open a new chart when we have results?
Kristen, I'm going to turn to you on this one. What is the best method from a documentation standpoint?
Can you repeat the question one more time?
Sure. Yes. So if we draw lab today and will not have results until next day, that's the case. But where do we document the results? Do we hold open the chart and document when we get them, or open a new chart and we have when we have results?
Yeah, I would not hold your chart open for the results.
No,
Close your
no.
chart, wait
Yeah.
for the lab results to come in, and then either address them with an addendum
Yep.
or on like the patient's follow-up encounter. So if you're going to call them back to go over those results, document it there. Otherwise, add an addendum saying, you called the patient and whatever you discussed.
Right. We definitely want to close those charts out.
Okay, all right.
Yeah.
The next question I can answer, can I please have these slides sent to us? Yes, as I asked earlier. We will have it. Yeah. Go ahead, Jennifer.
I said definitely for that.
Yep. Yeah, we will have it over to you in a follow-up email. You will have the recording as well as the PowerPoint presentation slides, and you can refer to them again and again. So moving on to the next question. So patients that come in for nursing visits like lab draws, injections, etc., is that also based on time?
All right. So what? I'm sorry, dear. What type of patient?
No. If a patient just comes in,
visits.
Yeah, nursing visits. No, it's not based on time at all.
Okay. The next
and
question.
You'll actually notice the 99201 that they deleted is a nursing visit code.
Absolutely. Yep. I was just going to say that.
Okay.
All
right. I'm moving ahead. Will there be a possibility of 99417 built into two, like built twice, built into two?
So
like what, 2 units?
Yes.
Yes. So you would basically take, anything over 75 minutes in 15-minute increments. So if you had 120 minutes with the patient, you would be billing 3 units of 99417. If I did the math right on the top of my head.
You did. Yep.
Okay.
You have to make sure we stick to that 15-minute interval, okay? And then we could times that 99417 times 2 times 3, depending on what the outcome of the total minutes were.
Okay. Moving on to the next question, will our E&M coding be updated in Prognosis? Yes, we did answer that earlier. It will be done in January.
Yep. Yes.
The next question is more like a statement. Right now, it goes off the old guidelines. I don't know if it is related to the MDM guidelines, but do you want to throw more light on it, Jennifer and Kristen?
Okay, so question,
It's just a statement that right now it goes off the old guidelines.
yes, these are effective January 1, 2021. So right now on December 17th, we're still in 2020. So we will need to use those old guidelines until the next few weeks.
I'm just going to add, it is data service specific. So
Yes,
if in January you still have December charts open, you're following the old coding rules for those. So it is data service specific.
Yes, it is. Thank you.
Okay. The next question, what about 99307 and 99308? That's the question. What about these two codes?
That's like a subsequent nursing facility care code.
So still follow the old guidelines. They did not change.
Okay, all right. The next question is, does all plan cover incident 2?
Okay, well, it's gonna.
Does all insurance carriers cover incident 2?
All carriers.
Yeah, I mean, yes, they do. You just have to make sure some of them do require the nurse practitioner or physician's assistant to be credentialed.
Yes.
So you want to make sure you're checking to make sure, do you need to enroll that NP before you can start billing incident 2?
Mm-hmm. Yes.
So the next question is actually based on a particular use case. So let me read it out to you. And if you want me to repeat it again, I will. So the question is, a patient is presented with knee pain, documentation made 2 out of 3 elements and performed genicular knee injection. Still bill the E&M code with 25 modifier and the injection under ultrasound guidance. Do you want me to repeat it again?
Yes, please.
Okay. So the patient is presented with knee pain and the document made 2 out of 3 elements.
Okay. So they're selecting them through their grid based on the okay.
And performed genicular knee injection, right?
Okay.
Do we still bill the E&M code with 25 modifier and the injection under ultrasound guidance?
Absolutely. So that was in one of my slides here. It kind of sounds similar to the Toradol. Okay, but yes, we would add the 25 modifier, and I'll add that in as well. Thank you, Dia.
All right. So the next question is on opioids. We care for pain patients and prescribe opioids, which are always high risk and carry risk of high mortality. How would you factor this in? Anything on opioids? How do we do that?
Kristen, I'll let you take this one. You're an expert in pain management. So.
Dia, could you repeat really quick?
So we care for pain patients and prescribe opioids, which are always high risk and carry high risk of mortality. How would you factor this in, I think, in the billing for opioids?
Oh, so if you notice on, I forget what number slide it was of that diagram where it says moderate risk of morbidity, what qualifies under that is prescription drug management. And that would be a 4 series. So if you go up to the, there you go, prescription drug management qualifies you under the 99204-214. And then depending on how many chronic illnesses the patient have, that will determine your level.
Okay, all right. So the next question is, please define total time.
All right, so total time is defined as total time spent on the day of the encounter. So the E&M code is selected based on the total time of the visit. So that was that one slide where we got to that 80 minutes. That's your total time. Thank you.
Okay. All right. For clarification, incident to billing means you bill with supervising data, right?
Yes.
Question. Okay, all right. So moving
Okay.
here is another question. It's a long one. I'm reading it out to you. Let me know if you want me to repeat. If the medical assistant, PCC, primary care coordinator, or a PA, not an MN, is not in the building but sees the patient through a video call, but the doctor is in the building and sees the patient after that, the time of the medical assistant, will that count?
The medical assistant, no.
No, it will not.
No, your staff time does not count.
No.
So a nurse or a medical assistant, their time is not part of the visit.
Mm-mm.
Okay. So moving on, if we charge for procedure, are we able to use time spent during the procedure towards total time?
Repeat that
If
again?
Yeah. The question is, to clarify, using time. If we charge for procedure, are we able to use time spent during the procedure towards total time?
no,
No.
because you're getting paid for it already separately, you can't include it in your time.
Okay, all right.
So anything that you're going to bill for separately and get paid for separately is not a part of time anymore.
Okay. So here's again, the next question is a particular use case. I'm a NP who owns my clinic. I'm in my state, a collaborative MD. In my state, a collaborative MD is not required to be on site with the NP. So how will billing affect me when you say an MD must be on site with the NP who sees a new patient?
That's only for incident 2. So incident 2 billing is basically when an MP or PA is billing under the MD's name as they're supervising. So if you're an MP that owns her own practice with no supervising MD, you wouldn't bill incident 2. You're just billing under yourself.
Yeah.
Okay. All right. So the next question is on a particular code 90833. So what is the new time factor for 90833, and can we combine 99213 and 90833?
So 90833 is a psychiatric code, if I'm not mistaken. So again, they want to build the 90833 with, let's say, a 99213.
Mm-hmm.
Well, it's not part of your medical decision making. You have to make sure it doesn't go into that, and it's not part of your time.
No.
So if you are billing for a psych test that you're doing, you can't include that in time or medical decision making on your E&M.
Yeah, because that kind of would be an inclusive type issue. So no.
Okay. So the next question is, when using time, you stated we had to document the time. Should we document time in and time out, or just total minutes? And if just total minutes?
You have to break up what you did on your time. So you don't want to do time in and time out. You want to say, I spent 10 minutes face-to-face with the patient. I spent 20 minutes in review of records. And you want that at the bottom of your progress note. And then you want to add all that time up. So total time spent on this visit, 40 minutes or whatever it was.
Okay, so actually the question says that it's just total minutes by category, like F2F, MR review, P2P, ordering, etc.
Yes, that's fine.
Okay, all right. So the next question is a nice statement which says, thank you for the webinar, very helpful. So that's for you, Jennifer and Kristen.
Thank you.
So,
Thank you, Kristen. Thank you, audience.
So the next question is, so if the provider is reviewing lab work a few days after the patient appointment, should they open a new note to document that? And if that gets sent over the nurse to contact the patients, is that billable?
Well, we talked about the addendum.
No, it's not. It's not billable. So the only thing you can include in time is if it's done on the same day. If you get a lab result a few days later that you're reviewing and the nurse contacts the patient, you can't bill for that.
No.
Okay. All right. let me take, we have a few more questions. Let me take one more question, and then I will hand over all the questions to Jennifer. And then
Yeah.
Jennifer, you can reply that in an email.
Absolutely.
Okay. So the next question is, we are podiatry office and we see patients take X-ray, debrid, nail, and callus. Can we bill this as 99203 or 99204?
So they're doing a debridement and X-ray, and they want to
Yeah.
know the section of the code. So again, that would all depend on the number and complexity and the risk of complications. They'd have to make sure using that grid. So I would say a debridement with an X-ray, I would think would be an 04 or 14.
I'm just going to interject really quick. If you're billing for the X-ray separately and the debridement separately, it doesn't count in medical decision making.
Mhm.
So you can't say that you can't go to the second column and say you did have an X-ray reviewed if you're planning on billing for that X-ray.
Mhm.
Okay.
And debridements are usually billed separately.
Yep.
So that you can't calculate that in your medical decision making.
All right. Just a few quick questions on coding. Was the E&M code 99211 nurse visit deleted?
No, just the 99201.
Okay. Okay. All right.
Due to that low utilization. Okay.
Okay. All right. So just this very last question. So we are not using add-on codes with these new changes.
I'm not sure what that add-on code means.
Yeah. So
Okay.
I need more clarification on what you mean by add-on codes.
Let me note this, and I'll have it over to both of you so that you can, email the person who's asked and then maybe get more details.
excellent. That sounds fantastic. Thank you.
Yeah. Yeah. A few more questions, Jennifer, Kristen, which I have with me, and I'll have it over to you.
Okay, great.
Yeah. So thank you to both of you once again for all the to all the questions. And I once again wanted to repeat that you will have the slides and the PowerPoint of the presentation in a follow-up email. And Jennifer, can you have that slide up? For all the non-prognosis customers, you can contact us at sales@bismaticsinc.com. And for prognosis customers, you can contact us at support@bismaticsinc.com for any questions that you have. A few of the questions which we could not answer will be answered in a follow-up email to the person who's asked it. So thank you to all our attendees for taking out the time and being here with us today, despite their busy schedule. We thank you all, and stay safe, stay healthy. Bye from all of us for now from Bismatics. Thank you again.
Thank you all. Have a wonderful, wonderful day.